Good afternoon. This is Erin with the Department of Medicaid. It is not quite 10 o'clock and the waiting room is clearing out, so we'll give it just a moment before we get started. Okay, good morning. Can everyone hear me?
Yes, thank you.
Okay, quiet
Yeah.
bunch this morning. It is 10 o'clock and the waiting room is cleared. Stephanie, I saw you, Barry, and Dennis log in. Did I miss any other board members? I knew we have a few members joining today, and I wasn't sure if I missed anybody when they were logging in.
I don't believe that I saw Brandon Harley, who is a new member of the TAC. And then we have one position, we're working to add a physician member to the TAC. And we have one physician who's considering that invitation and will hopefully get back with me soon on that.
Okay, great. I can keep an eye out. I also do not see where Brandon has logged in, but I can keep an eye out for you.
Okay, so with three of us, Erin, would that establish the quorum?
Yes, because there's three of the five. Sorry about that. I was counting.
Yeah, thank you very much. So with a quorum established, Barry, Dennis, do you, either of you have a motion to approve the minutes from the prior meeting?
Make a motion to approve the minutes.
Thanks, Barry. Is there a second?
I'll second.
Right, since there's three of us, I agree, so that motion will pass. So moving on to old business, updates on the PHE wind down redetermination. Is there someone from DMS who could provide that update for us today?
Good morning. This is
Hey.
Monica Judy Cecil, Senior Deputy Commissioner for Medicaid. Nice to see everyone this morning. I've got a short presentation. Let me get this started and shared. I won't take too much of everyone's time. Let's see here. Okay. So and if you attended our stakeholder meeting, this may look a little familiar because I'm just sort of recycling. Nothing's changed since last week. But if you haven't, hopefully this is providing you some great information about where we are right now in unwinding. Just a reminder that we are maintaining some flexibilities during the unwinding and the restart of renewals. They are really mostly focused on helping us handle the workload because, having not done a renewal in 3 years and restarting that causes a great deal of additional work or increased work on our eligibility workers. So a couple of things that we've done and wanted to highlight that I think are most effective that help our members is one, if you're a long-term care or 1915C waiver member, you can have your renewal due date extended up to 3 months. The reason for this is because their renewals typically take they're a little more complex and take a little more time to gather information. And so if the member hasn't responded to the notice that we sent them, they can take up to 3 months to submit that back to us. And then for the rest of the population in Medicaid, we're giving them a 1-month extension. So if they haven't submitted their response to the renewal notice, then they can, by the time their due date comes, then we can extend for an additional month. And then just a reminder, so if it's a child, we did automatically extend that child's renewal for 12 months. We really wanted to keep our kids covered, and what we see is they generally come on and off because of a renewal, but they always are typically eligible. So we have a high eligibility rate, renewal rate with our child renewal. So we did that. And then in December, to help our workforce, we did redistribute active renewals. By that, I mean, if we weren't able to go out and automatically renew the individual based on our trusted data source, we wanted to keep from having them to take an active approach to their renewal. And that means that our workers wouldn't have to process that case. So we then redistributed them for the rest of the unwinding period. So if you're really interested in what all the flexibilities are, we do have a tracker out on our unwinding website. Other thing to note, because I couldn't recall if we had talked about this in our last meeting, CMS did notify states that the flexibilities they've approved are actually eligible to extend to December 31st, 2024, which I think is just great news, because one of the things I think CMS and states have realized are some of our flexibilities are really like common sense things we should just maybe do permanently. And so they're thinking about those things and how to implement them on a permanent level. Not all of them. They're taking the time to review each and see, is it something that they want to implement permanently? How that affects Kentucky, we're still evaluating, because there's a lot of detail to that we need to get in with CMS to make sure we're following their expected guidance. They were really broad in announcing this, so still working on that, and we'll keep folks updated on what that looks like going forward. If you're just to note that our 1915C home and community based waivers flexibilities are a bit different, and we've been tracking those a little bit separately, but all that information is also on the unwinding website. There have been separate stakeholder meetings around the waivers as information changes. It's not a monthly thing, but just as information changes. For now, I will say that the only change from reporting this previously is that the Model 2 waiver has been approved with effective date of February 1. So that means that all of those now are permanent, or anything that was contained in that Model 2 waiver is now permanent. If anybody has a question about how this may affect you, certainly we've got frequently asked questions out on our website, or you'll see here on the top right, we have an email address specific to the 1915C waivers and a phone number. So a provider or a member could call that if they need to understand how that affects them. As noted, and what we continue to see and show every month is a decline in our Medicaid enrollment, not unexpected, because we knew under the 3-year continuous coverage that continuous enrollment that folks probably were becoming ineligible due to income primarily, lost of a categorical eligibility. So not too surprising. Obviously, we're making sure that as people terminate, especially if it's for lack of response to a notice, which by the way is about 60% of our terminations, we're still trying to contact those folks and just make sure they have other coverage. That's sort of what we're most interested in seeing. So this looks a little busy, but I'll explain it to you and you'll get these slides. So don't feel like you have to absorb it all now. And I'm not going to go through every one, but what we had been showing folks every month is the CMS monthly report that we're required to file on the 8th of the month following the renewal month. So, so for May, that was June 8th, for June, that was July 8th, and so on. CMS at the end of last year, updated their guidance to us, which is always fun, and changed our reporting requirements and have asked us to report the 90-day period following the renewal month and any cases that were actually processed that were pending when we made the original CMS report. So on the left-hand side here is that original report we filed. On the right-hand side is updating the numbers after that 90-day period. This report then gets filed 90 days plus 15 days after the end of the renewal month. So as we move forward, following that 90-day period on the 15th of the next month is when this gets filed. These are all on our website now. We've even the updated reports, and we'll continue to update them. But just as an example, let me walk you through May so you understand what you're seeing here. Originally, we reported 80,673 people renewed, going through renewal. 37,182 were approvals, 34,124 were terminations, and we had pending at the time of the end date, which was May 31st, 2,698 who were pending processing. That means somebody filed something, submitted something in response to their renewal, and the state hadn't had a chance to process it. In that 90-day period following May 31st, we were able to process 2,659 of those pending cases. And so all these numbers changed. So the approval number went up, which is great, 38,552. Termination number went up to 35,413. We still, at the time of this, pulling this data, we still had 39 pending. So this is data reported, and I'm going to have to use my fingers, May, June, July, August, through end of August. And so at that time, we had 39 pending. So, you know, again, you can kind of walk through this. Maybe you can't get to sleep at night and you want to pull this up and take a look at it. But, you know, you can kind of see each month how those pending cases were processed.
Hey, Veronica, what
Yeah.
caused the uptick in September? We had an uptick on renewals, and is that just kind of the timing?
Yeah. No, so thank you for that question. For us to implement that 12-month automatic extension for children, we pushed cases with children in it to September, and then distributed them across the rest of the unwinding period. So that's why we have a large number in September. So in the approval bucket, there are a lot of children, obviously, because then we automatically just renewed them. But that's why that is so much higher.
Okay.
Great
Okay.
question. And you'll see October is high again too, for that reason. And we dropped in November, December, because we had made a intentional decision, because those are months that have a lot of holidays, to make that a smaller caseload already. And then, as I mentioned, in December, we also pushed renewals based on that redistribution. So still tracking. In fact, we just completed the number for October. We haven't updated this yet for that 90-day processing, but you know, here just noting that we're still tracking the reinstatement. So if a member was terminated and is able to come back and give us the documentation we need to make a redetermination and they're eligible, that in that 90-day period, reinstatement period, we will reinstate them back to their original termination date with no gap in coverage. So important to always know, if you have somebody come into your office, they've just been terminated, but in that 90-day period, we could still possibly get them covered. So important to have the conversations with them about responding to that notice still. So looking at the most recent month, January, 121,236 individuals were up for renewal. We have a very small approval and termination number, and that is because we have, you know, extended based on our extensions, extended a lot of folks. So that's why there's a big extension number there. And then just a reminder, we have a demographic data report that is on our website. Starting in September, we started reporting a couple of demographic metrics. So race, ethnicity, age, and gender. And then we break down in the report by county approvals and terminations. So if you're interested in the counties that you serve and you want to go out and see what does that look like, you have that information available to you. The other thing we do is we kind of track this to make sure, like, for instance, children, just because we're automatically extending children 12 months doesn't mean that they won't terminate during this period of time. They turn 19, or they moved out of state, or their parent or guardian came in and asked us to terminate their Medicaid coverage because maybe they have coverage some other way. So but we look at those particularly and go back and look at the actual cases to make sure that it was processed correctly and we weren't unintentionally terminating a child. But this also helps us track at the county level if we see wide variation in especially terminations, and is there something we need to be doing in that particular county to make sure that folks are responding to notices, are aware of the renewals, and should we do some additional outreach for that? A reminder on our website.
Veronica, could I ask a question?
Yeah. Sorry, Stephanie, go ahead.
So, and I can go to the website after the meeting, but I just wondered, is the N that you start with or any percentage on there? Because, this appears to be raw numbers. And so, for instance, we take care of Madison County, but also Jackson County. The population of those two counties is very, very different. So am I losing, does the outreach need to be in Jackson County, even though the number is smaller, but it's a higher percentage of their covered lives? Do you get what I'm asking?
I do. And we look at the rate based on population. So if you're absolutely correct, there are two different numbers based on the population, the Medicaid population, and who's going through renewal. And so we look at it by rate so that we can capture that. Great question. So again, lots of information. You guys, we encourage you and hope that you pull down some of these and post them as members come in. Maybe they're sitting in your waiting room, giving them information about their renewal and reminding them that those are happening. And then the particular one is like this middle one, or well, second from the left, is a really great one to give really high level information. Perhaps they were just terminated, and so this far left one is about reinstatement and what they can do to get reinstated. So just lots of information out there. It's also in Spanish. If there's anything that we can do differently, we're still open, and unwinding is still going on. So not too late for us to generate a new informational bulletin or flyer for you if there's one that you think is needed. Reminder for providers that in Kentucky Health Net that members' renewal date is on there. If you don't see a renewal date, it's because they're categorically eligible and they don't have an annual renewal. So we do have some members that don't have annual renewals. Their Medicaid eligibility is covered because of their being in that category. Foster children are an example of that. So if there's no renewal date on there, no problem. They're not subject to renewal at the time, and then they can, just for the ones that you see the renewal date on there. If your long-term care, your information is in clocks, or if you're a waiver member, the information's in the MWMA. Always want to plug qualified health plan because as people roll off Medicaid due to income, we really want to make sure they're covered. Maybe they're covered by an employer insurance plan, but if not, then we want them to go out and choose that qualified health plan so they maintain coverage. The open enrollment period for that closed, but the good news for Medicaid members that are rolling off is there is a continuous unwinding special enrollment period. So if at any time between March 31st, 2023 and December 31st, 2024, and this hasn't been updated, my apologies. We just got approval to extend that to December. Anytime within that period of time, that Medicaid member, that the previous Medicaid member can go and check a box and say, I lost Medicaid, and that will open up the ability for them to choose a qualified health plan outside of open enrollment and outside of that qualifying life event. So losing Medicaid is a qualifying life event, but you only have about 60 days to go out and choose that plan. So during unwinding, you know, we're trying to make sure everyone understands if you lost Medicaid, you're not covered, don't worry about the open enrollment period. You can go out and do it anytime during this period of time. So the good news is, as we saw Medicaid enrollment, you know, trend down, we're seeing qualified health plan enrollment trend up. We had, I think, my understanding is the largest enrollment during open enrollment. So that's amazing. 75,821. This blue line is last year, 2023. And so you saw there was actually a decline. So this is a great trend up that we hope to see maintained throughout the year. Oops, sorry. There's our website. Again, lots of information, all of the reports, the CMS reports, updated reports, demographic report, frequently asked questions, stakeholder meetings that we have every month. They're all recorded. So we know it's probably hard for you all to get at 11 a.m. to jump on a call. But it's recorded for you to watch later if you're interested in staying up to date. Just a reminder, Twitter, Facebook, and Instagram, we post, you know, really current information. You don't have to do all three, just one. We share the same information across all three platforms. So if you haven't liked us or followed us on one of those, we appreciate you doing that. And then, you know, just trying to remind folks there is a lot of information out there, and we hope that it, you know, you can access it and understand it. I will stop there. Oops, sorry. I did not stop. There we go.
Additional questions on unwinding? All right, so moving on to wrap payments and how the new system is going. I was not on the last call, so I'm anxious to hear how people's experiences have been.
Sure. So I'm happy to take that too. We had our meeting December 8th, and really it was actually kind of a fairly short meeting in terms of agenda items. Prior to that, and sometime in mid to late November, there was a problem with encounters coming in and generating a wrap, and it's funny how things start to bubble up, and you hear one thing, and then now you hear it from another provider. And what we did discover is the file coming over from the MCOs was delayed for various reasons, and so that was delaying the generation of the wrap. The good news is it wasn't a systemic issue or any problem there. They quickly caught up, and I believe resolved following that. We did talk about the new reconciliation process. Still, you know, if any providers out there, that should have been sent out to all providers now. So if you're having any trouble navigating that reconciliation process, that was, you know, our first iteration. Certainly happy to take feedback and see if there's anything we need to tweak for it. But that's out there, and hopefully providers are able to utilize those tools that are available to them to reconcile their claims with their wrap payment. The next meeting is March 14th. One of the things we did discuss, and I think I've mentioned this on this call, is we did procure a vendor and are working on implementing a new claims processing vendor. So it's called MMIS now. The new name is the Medicaid Claims Administration and Financial Solution. MCAS is our acronym, because you can't be a Medicaid without an acronym. So MCAS was originally slated to go live early in January next year. We just completed requirements on it, and so we already know it's going to be delayed. So we're probably looking more in the second quarter of 2025. So we still don't have a lot of, we're still working on the design and don't have a lot of information yet to give to providers on it, but we do hope that and plan when we are at a place where we can walk through it with providers. We'll be reaching out and having those meetings so that folks can understand it. And we'd be happy to, bring a specific presentation to this group, especially about how the wrap's going to look through that new system. So, so that's, something we'll continue to have on our radar and present to you all when we have a chance.
Do you anticipate that that new system will be able to do like bulk uploads of claims, or is it still going to be a one at a time process?
I can't answer that question, Stephanie. Yet.
Just know that we
Yeah.
in our hearts. Sammy, I think you probably would jump in and agree with me that that would be helpful to people.
Okay.
I agree. Yes. Thanks, Stephanie.
Okay. I have noted that, and I'll get that back to the implementation team.
Because I think that has been, what I've heard from my team is that you want to go out and collect that wrap that's doable. But then you're in this situation where you're particularly now with the cost of labor, considering what am I going to actually collect versus what it's going to cost me to go out and complete that process. So I know that we've had to hire one FTE dedicated just to managing that process for us. We hope it will yield more than we're paying them, but
Right.
that remains to be seen. So
Okay. No, I appreciate that. I know I just hesitate to talk specifically about the system yet. My understanding is that we're trying to mirror what is going on in Ohio, and my understanding our providers are very happy with the way that wraps are generated in Ohio and paid and generated in Ohio. So but again, I think just a little early to talk about specifics, but I'll take that back.
thank you.
Yeah.
All right, so moving on to new business, we did work with DMS to set a new tax meeting schedule. So hopefully those dates have been shared with you. And we really intended to kind of mirror the meetings of the MAC. So we'll be meeting 3 times this year. We're hoping that, we can make those meetings a richer experience for all participants and keep our schedules a little free. So Veronica, we're going to turn it back over to you for new business from DMS. Sorry, we didn't give you much of a break.
Thank you. I tell you, I wanted to show if folks weren't able to be on the MAC, the commissioner did a presentation of accomplishments. And so this won't take very long, but I did want to show, let's see here. Oh, just we always have this Medicaid at a glance. So we're at little over 1.5 million, $16.8 billion for state fiscal year 2023. We continue to grow. This year is like 17. This 2024 state fiscal year is going to be like 17.4 billion. So that continues to grow. But this is what I really wanted to show you. This is not an exhaustive list. So these are things that we did, that we kind of consider sort of major changes to Medicaid. So this doesn't include all the other little things that we took care of, or policies we might have changed from 2020 to 2023. And I'm not going to go through all of these. We'll send this presentation out so folks can look at it. But a couple of things I did want to note. We eliminated copays, which, I didn't get a lot of acknowledgement or discussion. It just like happened. And some of that is because we had waive them during the public health emergency. And what a lot of folks don't realize is we just carried that on because we made it permanent. So that, you know, that made sense to us, and we were appreciative. At the time, Senator Alvarado sponsored the legislation to put it actually in statute, because we know it's the provider that has the administrative burden of collecting those. And so it comes out of your rate. And so we thought, why are we doing that? So that was a big one. The other thing is the postpartum. So we, you know, expanded coverage of postpartum from 60 days to 12 months. Another like no-brainer. Why would we stop covering you know, someone who just had a baby after 60 days when they've got a lot of necessary care that needs to happen? So now they have that 12 months coverage following postpartum. We another couple of other things you all are certainly aware of: community health workers. We started covering and reimbursing. We also got approval for a state plan amendment for treat no transport. And what that means is if an ambulance, emergency services responds to a call and they actually perform some type of treatment, but they don't transport the individual, they can get reimbursed. Makes sense. You know, that because before they were required to take that person to the ER and only the ER if they wanted to get reimbursed for that service. So now they can go to the call, they can maybe triage and provide some care and not transport somebody because that's taking care of it and they can get reimbursed. We have pending right now treat, triage, and transport. And what that means is we will, after that gets approved, actually pay for them to transport to someplace other than the ER. Also makes sense. So maybe somebody doesn't need to go to emergency room, but maybe needs to go to some other setting. It could be to an FQHC or RHC. It could be to a, you know, some behavioral health setting. So now, you know, once this gets approved, when emergency services responds, they can if the person needs something beyond what they're able to treat, they can transport them. So we're waiting that for that approval to come through. During this period of time, we implemented the hospital rate improvement program for inpatient and outpatient, and we also did the university hospital program and the ambulance provider program. And what that means is we now are tying quality metrics to reimbursement for those 4 areas. So for additional payment, they have to perform and meet certain metrics. This is where Medicaid wants to go to in 2024. You all have heard about the managed care organization value-based program. Started in January, and we're wanting to align the metrics across all these different programs so that we're all working together towards the same goal in improving the outcomes of our members. So still moving that way. We also started covering non-emergency medical transportation to methadone treatment. Previously, when we implemented our 1115 for substance use disorder, it was a carve out to pay for transportation to methadone, but now that we have carved that in, and so that is covered. The last thing I wanted to note, and that you all probably are very familiar with, is that we enhanced the vision, dental, and hearing benefits for adults. Again, one of those areas that's kind of a no-brainer, especially if it's a Medicaid member who started coverage with us as a child and then transitioned to adult. Why would we cut off those services to them? And oral health is just evidence shows that good oral health can also either improve somebody's overall health, or if they have poor oral health, is an indication of something else going on. So just again, a long list of a couple of things that we did during that period of time. In 2023 alone, we had over 20 state plan amendments approved. I know you all probably don't understand the context of that, but that's enormous. Like, that is a record-setting number of state plan amendments. So lots of major changes to our program. I want to note that Aaron Bickers and Kelly Sheets, who are our MAC and TAC liaisons, are the ones that actually submit those for us. So not only were they working with you all on your TAC meetings, but they were also helping us prepare and submit and get those state plan amendments to approval. We also amended to Kentucky Children's Insurance Program, SPA. So anything we do in K-CHIP has its own state plan amendment that's required. So we did 2 of those. Those 4 directed payments are those rate improvement programs I talked about, the hospital, inpatient, outpatient, university, and ambulance. We were, for the first time ever, fully staffed. It has never happened in Medicaid. We have generally have been about like 65 to 70% of our vacancies filled. We were able to fully staff. And what we're hoping you all will see is that we're able to be more responsive. We're able to really do the things we should be doing, which is looking at quality, trying to drive better outcomes, assisting providers with understanding the benefit and reimbursement, working with providers about reimbursement. We just really have not had a lot of extra resources to do that, and so that we're really excited about what's on the horizon for all of us. And then during this period of time, we published our first ever Kentucky Medicaid annual report. It was for the 2020 state fiscal year. We're working on 21, 22, and 23 right now, and we hope to have those released in the near future. This was a major initiative of the commissioner. She wanted to be able to tell people our story. Who are we covering? What are we paying for? What does that look like? So more on that in the future. Other than that, we talked about MCAS, because that was just the other thing I'd like to always keep on people's radar is that happening. And and then the commissioner just really wants us to continue to focus on quality and population health initiatives. What can we do in Medicaid that we can also do across the state with other insurance coverage, or with the Department for Public Health, to continue to improve Kentuckians' lives. So that's all I got.
Thank you, Veronica. And please give the commissioner our gratitude as well. I think that, when you look at that list of accomplishments, primary care touches so many of those things, even the changes with EMS, really impact, how we're passing patients back and forth between different settings of care in our community. So we appreciate that work, and we appreciate that commitment to intervention and to collaboratively trying to solve problems that allow us to take care of patients. So thank you to you and your team.
Thank you. Thank you for those kind words. I certainly will pass that on.
So moving on, we also have the crisis stabilization program on the agenda. I don't know if you're prepared to talk about that.
We actually do have, I think we have somebody on who is working on.
I am on.
Yay. Okay. Do you have a presentation?
Leslie didn't give me one, but
Okay.
I would be glad to talk about it. And if there's any questions, well, I'm sorry. I cover, currently under in Medicaid, we have residential crisis stabilization units. That's where someone can go and spend the night if they're in a crisis. They don't really meet criteria for a hospital setting, but they need to be somewhere. We have, in one of those SPA improvements that we have received from CMS last year, we received the approval for to add a service. We call it, it's under 23-hour crisis stabilization. So someone can go there and stay 23 hours or less if they are in crisis and that crisis cannot be stabilized. Where they are, they just need to be away out of the physical location, or the situation just can't be resolved. They can go to those locations and stay for amount of time that's medically necessary. They will receive a medical evaluation, a clinical evaluation, other support services that they may need, care coordination, so that they can, once they leave the 23-hour, we need to work on a plan, so that if you're in this crisis again in the future, what can you do to to settle or de-escalate the situation yourself. These are going to be available to our CMHCs and our residential crisis stabilizations. You can now either do a 23-hour and a residential, or one or the other. Are there any questions, or did I explain it well, or any leftover questions?
I know that, and please don't laugh when I try to show you this, but
Oh,
this
no.
graphic,
Yes.
it's really blurry. Can you tell which one it is?
Yes, I definitely can tell that which one that is.
One of the things that, after Secretary Freelander's, presentation, our primary care and our behavioral health team feel a little uncertain about the space of primary care kind of on this graphic, because oftentimes the CMHCs won't respond to our office because they think that we have professionals here who can do that evaluation, but we're providing outpatient services. We're not equipped to do crisis stabilization, but we're the places where people show up in crisis.
Correct.
And I mean, it's disruptive, and I don't say that from like a space of an annoyance, but like it more from a place of impeding our ability to care for the other patients that are in our clinic at that time. And so,
Okay.
one of the things that we're really curious is, how DMS sees primary care sort of on this graphic and in this metric, and where you feel like we fit in this plan.
That is a very good question. Honestly, we haven't thought about that. So I'm going to take that back to our team and to our ASO and say, where do they fit in? I guess you're having people that present to your office in a behavioral health crisis, because sometimes, they don't know elsewhere to go but their primary care. And from that point, where do they fit into the crisis continuum? Okay.
Right.
I will definitely take that back and get an answer treated for the next TAC.
Yeah, we don't want to send them directly to the ER.
No, correct.
They,
Thank
don't
you.
necessarily meet criteria for, inpatient admission. And so they're just like in this interim space, and they're looking to our team for help, and
Okay.
it's really difficult. So yeah.
Something else that you can do is, and you probably don't have the staff for this, or, but if someone's in a room, if they can call 988 from your office. And then kind of, there will be a call taker on that end that can help with that issue. And then does that need to be referred on to a clinician or referred on for a mobile crisis dispatch? And that would be an appropriate setting to send a mobile crisis team to your office to meet with that individual that's having the behavioral health crisis.
It has been our experience that they won't respond to our office. So, maybe that even needs to be part of the communication, and we can continue the conversation offline. I just wanted to bring it up that
No, absolutely. We can definitely, in part of the training, when we get, the ASO is going to be responsible for getting the mobile crisis teams contracted under them, but that could be definitely a approved place of services to a primary care office, because we do not have behavioral health embedded in our primary care offices. So that will help. Thank you for bringing that to our attention. And that can just be part of the training, that yes, that is an allowable place of where you can go for mobile crisis dispatch.
Okay, thank you.
You're very welcome.
Bringing up an excellent point that, in thinking through what is a setting that the mobile crisis team could be dispatched to, like, we're not going to dispatch to a hospital. We're not going to dispatch, that makes sense. But dispatching to a provider office, definitely makes sense, and just something we've
Absolutely.
not, been intentionally, thinking about. So it's great that you highlight that so that we can loop it into, to our, as we implement.
Yes.
And even if we have outpatient behavioral health integrated in that primary care practice, they're not necessarily connected seamlessly to the
Yeah.
next level of care. And so the mobile crisis team responding and then us being able to pass off the patient to somebody other than the ER would be fantastic.
Correct.
Absolutely. We want to keep them out of the ER. We want to keep them out of jails. And something you noted, just to kind of, hopefully, maybe address some concerns about current response, is that our administrative services organization, the ASO, is going to be responsible for holding providers accountable to what mobile crisis is, the fidelity of the service. They're going to have to be qualified and contracted to deliver that in accordance the way we are requiring it. So, we're really, I think that the exciting part to that is we cover mobile crisis right now, but not in the way that it should be delivered. So this is really going to change the environment in terms of mobile crisis delivery.
Hey, Veronica, this is Barry. Where will these mobile crisis centers be located at in the state?
They're across the state, and it is generally the current providers that are available. And Leanne, if I get to this is
Sure.
my area of expertise, but so they're all over the state. They're going to be providers all over the state. And again, I think the key point here is that they are going to be required to be able to meet our definition of mobile crisis, the services that are contained in the mobile crisis, the team, the criteria of the team. So all of that will be consistent across the state.
Is it going to be kind of like our QRT program, quick response team, to a certain extent, with a different
Leanne is the answer to
personnel?
that. Yes.
Yeah, kind of, sort of.
Yeah.
Now, in a mobile crisis dispatch, if someone calls 911, or 988, let's say, a mobile crisis team, they're going to get out within 2 hours of where you are in Kentucky, where the QR team, they reach out within 72 hours of the overdose incident, correct? So part of the responsibility of the ASO is to make sure that there are teams and providers available to reach to someone within 2 hours of a dispatch.
Okay, good. And then are you guys educating the law enforcement in regards to that? Because like we have a drug tank, a drunk tank, withdrawal management at our facility. And a lot of the law enforcement say they don't even know about it and they don't utilize it. So I think educating the law enforcement that this is available is going to be crucial as well.
Yes, part of our mobile crisis intervention service implementation that we're doing includes a co-response model that the cabinet has a grant program for co-response, either an EMS in a behavioral health or a law enforcement in behavioral health. And we have 7 of those around the state right now for our first program. And part of the ASO, again, is to educate law enforcement and educate others around the state that this is an available resource and this is available service.
Okay. Sounds great.
Next on our agenda, utilization trends from 2023.
So we saw this agenda item on here. I know that KPCA is working with our quality division to try to come up with some data points to be shared. I think that conversation is ongoing. We don't yet have the data available. So if it's okay, maybe we can park this on the old business and we can provide updates as we're able to pull that information.
Sure. That sounds
Okay.
good.
And Veronica, this is Angie Parker. I do have some preliminary data. It doesn't
Ooh.
include everything that was initially requested, so I can, I was looking to set up some time with those that we first discussed this with to kind of go over the beginnings of this information, so.
Oh, great. So
There's still
maybe-
more to come with this data, but I wanted to touch base to make sure that what we've been able to gather thus far is what is being requested.
Great. So maybe by the next meeting, we will have something we can go over.
Yeah, this is new news.
All right, so moving on to the updates from the PCA and CIN. Molly, are you doing the PCA and Dr. Hoagland the CIN, or are you tag teaming?
Yeah. Yeah, I'll be quick. Hi, everybody. I'm Molly Lewis, with the Kentucky Primary Care Association. Am I able to share? I just wanted to show you all something really quick.
Yeah, Aaron or can make you a co-host.
I'm working on it. Give me just a second.
Oh, sorry.
That's
I
okay.
should have asked in advance, but I was just
You're now a co-host, Molly. And if you
Okay.
don't mind, you share, please email
awesome.
so I can
Please.
throw it on the website.
Oh, awesome. Yeah, no problem. Here we go. So something that I've been thinking about a lot, we just finished with our KPCA strategic planning, and one of the purposes of a PCA nationwide, we're one of 53, is to be a point of contact or a representative of the interest of the providers in our state. And we're pretty unique in that we have federally qualified health centers, lookalikes, and rural health clinics. So if you look at this map of Kentucky, can everybody see what I'm looking at? This is where I've clicked just with the rural health clinics. So the Barry Martins, the Dennis Fauches, those are represented here with the red. And then if we add the FQHCs, you see the sites, more of an impact on the state. And then if you add the school locations, it's right here. And so I think that this makes a lot of sense for why we're here today talking about these things and how we can really increase the impact of these conversations. Veronica, all of those accomplishments that you all have that we're so grateful for, like if they're going to be successful, like we really need to partner on them, I think. And so thank you for sharing them with us. And thank you for running things by us. Those conversations that we have monthly, if not more, on what's going on, how things are landing. We really appreciate having those in order to show the impact of the PCA. So currently we're at about over 100 members, but if you look at this, when we talk about how we're responding to the needs of Kentuckians, nationally, I think the number of patients seen in this type of settings increased by about 45%. And it's just, as a place, what do we need to do in order to be the provider of choice, the employer of choice, the partner of choice for Kentucky's health system? And so I think that it's really a valuable time for us to spend together. And this, I'll send you this because it's on our website, but it's really helpful because you can break down like where everybody is and how they're located. And I think for the school locations, especially, you realize kind of the local flavor of having different models that meet the needs of the community. And they kind of work together with the Department for Public Health or work together with Medicaid, work together, the level of services that are available and how we're taking care of Kentucky's children in the school setting really varies from place to place. And so thank you for keeping us abreast of what's going on and for getting our input. We really appreciate it. We consider this part of what we do as advocacy, and just having those communications. We also, and what we're doing for excellence in terms of the level of services or what we're providing in terms of training or technical assistance in order for our members to be as high, to perform, to be high performers. So, what Angie's working on with the quality initiatives, this, and Steve can talk about that a little bit more. And the impact. I mean, if we can develop some activities, when we can do things in concert or to collectively together, we can really make a big impact on Kentucky. And I think that the fact that Kentucky's health status has improved, by several numbers over the past couple of years with your team, Veronica, I think that shows that we can make progress and we're tracking in the right direction. So that's all I have to say, but we just are grateful for this time together and we look forward to making it be as productive as possible.
Dr. Hoagland, you want to jump in with CIN update?
Sure, thank you. For the record, Steve Hoagland, I'm the Chief Medical Officer for the Kentucky Primary Care Clinically Integrated Network. I'll also be brief. Many of you have heard different iterations of this, so I don't want to bore everyone in rehashing. However, I think it is important to kind of give a little bit of the background. So the Primary Care Association is one of the organizing members of the new KPC Clinically Integrated Network, which began officially in service in January of 2024. And it is a primary clinical arm to drive improvements for many of the members of the association. It's important to note not every member of the association is a part of the CIN, but the majority are. In order to be a member of the network, you do have to be a member of the association, however. So the new KPC CIN has 91 unique tax ID number providers as a part of that network, with about 2,000 clinicians across the Commonwealth. So many of those dots that Molly showed are within the KPC CIN. The network currently holds more than 10 value-based agreements across all payer sectors, but the majority of them are in Medicaid. And so very important to this group as it funnels up information to the Medicaid Advisory Committee. There's actually more than 400,000 patients that are served under those value-based agreements, and over 300,000 of them are Medicaid members. So again, very important to where this committee provides information up to and recommendations to the MAC. An important initiative that's been undertaken, and again, many of you have heard this, is the network is sponsoring a data aggregation tool that will be used by the majority of its members over time. Now, it's not something that happens immediately, but at this point, and so that will take information combined from the patient management software of the participants in the network, as well as the EHR, and receive information from external sources, including the health plans, the HIE, et cetera, so that you have a consolidated source of information that we can use to help drive improvements. The goal is to have as many of those 91 groups connected as possible. That's a long-term plan. At this point, we have 10 to 12 groups that are in various stages of implementation. And by end of calendar year 2024, we anticipate over 30 groups being connected. That's part of our plan and projection, and that would represent about 60% of the attributed patients within the network. Another important data point just to throw out, on top of the more than 400,000 patients that are in value-based contracts or covered under value-based contracts is probably more accurate. The network and the association sees over 1 million unique Kentuckians per year. And it's pretty sizable, obviously. Roughly about 20% of the population of Kentucky seen by the members. So yeah, it's obviously an important channel for all of us to think about how we can help improve the health of our communities. So with that, I know the members of the committee have heard a lot of this, but it's a lot more for the other stakeholders. But happy to entertain any questions that may be out there at this point. Stephanie, I think you're on mute.
I am, thank you. So I said, hearing no questions for Dr. Hoagland, we'll move on to payer updates, and we switched the alphabet. So WellCare is up first this time.
Yes, good morning to you. Thanks for shaking it up with the alphabet. That's nice every now and then to get to go first. We appreciate that. Stuart Owen with WellCare. I'm not going to be talking. It's Brooke Hall, awesome with our care management team. I know y'all didn't ask for presentations, but to organize thoughts, I know Brooke has a couple slides basically about different ways that we steer members to primary care. So Brooke, the floor is yours.
Hi, this is Kelly. I'm sorry. Erin is having technical issues and she cannot unshare her screen
Oh,
at
that's all
this
right. No problem.
at this time.
No
Okay.
problem.
So she should be.
That works just fine.
If you can try to take over, but I don't know if it'll let you.
It is not. I was just trying
Yeah.
that and it didn't let me
Okay.
override that. So
I do apologize.
no,
I
that's
don't know what's
fine.
going on.
It was just 2 slides, just some
Uh-huh.
overview and highlights of kind of the map, the way that we view our primary care provider partnerships and how our initiatives drive members towards that primary care home. So at WellCare of Kentucky, we have all of our member-facing programs with a process flow documented guide, if you will, that suggests the most important aspect is getting and establishing primary care provider relationships. We believe that primary care is the cornerstone of wellness in our state. We want to see each of our members have the opportunity to have that trusting and engaging relationship with their primary care. So we have programs such as transition of care, where we have embedded case managers in hospital facilities that before the member even leaves the facility, they're discussing where their primary care office is located. Can they get there? What are their barriers to that? And making sure that they've got that appointment. We have health coaches and quality teams that are making hundreds and hundreds of calls a week to identify members that have missed a primary care appointment in the last 12 months. They haven't had their physical. We are making a very concerted effort on the well child pediatric space, plugging those kids back into a provider to act as their primary care home. We have OB, who not only works with the OBGYN involved with our members that are pregnant, but we also have that team that pushes the member also to the primary care location for overall health maintenance and preventative care. Our population health type chronic condition programs also all drive our members back to their primary care locale. So the way that it works is we are in a constant state of assessment. We're wanting to reach out to our members and then make sure that they're satisfied with their current primary care. Also that the primary care assigned in our system is accurate. And then we correct that if they are not accurate. We also work to find a primary care provider for those that may have a concern or feel like they would like to go to a different clinic or provider. We have a ED diversion program, which was a pilot in 2023 that has shown phenomenal outcomes. And the entire central theme of that program is establishing primary care relationship with those members to take them away from the utilization of the ED, move them to utilization of primary care. We want our members to be able to get to primary care providers. So each of the staff doing these outreach and making these calls to members definitely have a robust resource database and have a very high level working knowledge of the resources available in the state, from transportation options to housing to making sure they're enrolled in SSI appropriately, making sure that they have the resources that they need as far as food, just your basic SDOH barriers. We remove those to the best of our ability. We have an entire housing program that, looks for housing placement and housing stability for our members. Because what we've noticed in our ED diversion work and with some of our frequent admissions, the lack of food, the lack of heat, the lack of transportation is driving these members to be admitted or to the ED. And we want to remove those barriers so that they can be better served at the primary care home location that they have available to them. We work heavily with transportation. What we find is that, you know, we can get members to a specialist appointment using that non-emergent transportation resource through Medicaid. But if we have a UTI, strep throat, something like that, that 72-hour required scheduling prior to the transportation is kind of a limiting factor. So while we appreciate and utilize that non-emergent transportation option with a lot of our membership, we also have options that are put in place to get members to the provider for those sick visits. We have just a phenomenal data and analytics team here. So their role is to constantly evaluate the state of our members. So have they been to the PCP in the last 12 months? If they haven't, there is a revolving algorithm that then farms those members to an outreach program. We have also data that looks at gaps in care, data where, like the ED diversion program, discharge and readmission data that is kind of signaling to us that we may have a gap in that primary care relationship space that we're desiring for our members for their best outcome. One thing to note too is that we believe that we are good partners with provider. It's our job to be good partners with primary care. Through our IPAs, our value-based contract providers, through all the providers, we have 3,414 individual primary care providers in network for WellCare in the state for Medicaid. And we want to partner with those provider offices. We know that there are gaps that need to be closed. There's member outreach that needs to be made, and the ask for that to be carried solely on the provider office is a burden that is just too large to overcome. And so we use our data and analytics as well as our provider relations team. They're phenomenal at sending us provider panels. Hey, we haven't seen this member in 24 months. And then we go down the rabbit hole and we work hard to find that member and get them scheduled. We check out claims to see maybe they're going somewhere else, and we can reassign to the appropriate primary care and remove them from the wrong panel. So we work in conjunction and collaboration daily with providers in the primary care space to make sure that we have adequate coverage. We overlay heat maps. So as new members come into our plan, members leave our plan, we're constantly using those heat maps to make sure we don't have primary care deserts located in areas of our state. And then our contract and network team works diligently to shore that up in areas where there's been a change in the volume of membership. So we have just some excellent data and analytics that constantly is churning out ways that we can outreach to our members. And again, all of our programs, workflows, processes to the letter are driving members back to their primary care provider. We do every 30-day outreach. So if we don't reach you in 30 days, the first time we're going to try you again. So we are diligent. We work hard to close those gaps to make sure that our members are receiving the primary care services that we believe and know will be best suited for their overall wellness. Is there any questions about that or any clarifications on anything I shared? Okay.
Thank you, Brooke.
Sure.
All right. Dr. Cantor, I think I saw you turn your camera on. So
yes, good morning. Good morning. And I'm like Stuart, I appreciate the alphabet getting reversed. Thank you so much. From United Healthcare's perspective, and for those who may not know me, I'm the CMO with the plan. We did give a VAB list earlier. So if there are any questions, please let me know. Our updated VA for 2024, I think the couple things to specifically point out, car seats that we were able to give moms who complete their 6 to 8 week postpartum appointment we're so happy to be able to offer diapers. So 200 diapers if a mom completes their postpartum visit. We'll give age or size appropriate diapers to that mom. And we have a doula network, both telehealth and telehealth and person-to-person opportunity for our pregnant moms, as well as supplemental transportation, where we're offering rides to the grocery store, as well as other medical needs if they should need that. And that is for unhoused, justice involved members, as well as our pregnant moms again. Those are just a few of the VABs, but I did want to point out that we have a welcome letter that is clear to the members regarding their benefits. So I'm hoping that that becomes easier for them. We're adding on the back of the member's card a BH number that's specifically a crisis line phone number. And we've expanded the CP-PCPI provider incentive program with KPCA. And I really appreciate Molly and Dr. Hoagland's presentation earlier to share what that might be. It's simply an increase in the pay per gap, and we're putting more providers in that program as a whole. So really excited to be able to incorporate that into this large network. We have a Dare to Care Cooking Matters class in Louisville, targeting members with high hemoglobin A1Cs. And members that have diabetes, we're expanding home delivered meal programs to them. So that's some of the highlights that we're doing for member engagement. Any questions?
The home delivered meals is across the state or just in Louisville?
Good question. Nope, that's across the state is my understanding, because we're able to do that. It initially started for members who were hospitalized, had a diabetic diagnosis, or COVID when we were under the PHE. So that was statewide. So home delivered meals is still a statewide program.
Great, thank you.
Yeah, thank you.
Any other questions for UHC? Turn it over to Passport.
Good morning. I'm Yolanda Callher with Passport by Molina. Nicole Yates, our AVP of Growth and Community Engagement, will be presenting this piece. Thank you.
Hello, everyone. Thank you for the opportunity to present before you today. I just wanted to tell you just some highlights of things that we're doing at Passport for our members. So on the provider engagement side, we're doing e-news communications that are sent to registered providers, announcing education programs, and members can benefit from those requests. Provider action of helping to push such education and help complete the forms, etc. And then there's quarterly provider newsletter. The quarterly provider newspaper contains articles along with the provider services representation that also pushes education to providers via the monthly JOCs or other avenues of communication. On the community engagement side, we do a lot of member education sessions virtually every day of the week and in Spanish. We do lots of advocate sessions, meetings with advocates, CBOs, FBOs, and one-on-ones about our benefits, along with sharing information with community partners and at community partner meetings, such as the health councils, coalitions, and then KYA, SAP, etc., and just across the state, we do a lot of that. Members can come into our one-stop help centers that are located in Covington, Owensboro, Bowling Green, Hazard, and Lexington, and get some one-on-one, and that happens from 9 to 5, Monday through Friday, local time. And then there's a specialist in there. We also hold different educational classes, and we can help with the value-added benefits. We provide health education virtually in person, and then again at the one-stops with flyers and other things that we share with our CBOs to inform them. and the members of our trainings. We use social media platforms as well to educate and inform members of upcoming events. Our members receive, in communication style, new members receive a welcome kit that contains a member handbook, quick start guide, member ID card, HRA forms, the PCP selection form, a business return envelope so that they can return those forms, notice of privacy and practices, and then there's a maternity flyer for female members age 14 to 50. That'll be coming soon. And then we have a member newsletter that goes out 3 times a year to all of the head of households that contains all of our new initiatives. So that's just a few things that we do at Passport by Molina to engage the members. Any questions? Okay, thank you for the opportunity.
Hey, Nicole. I'm sorry, Stephanie. I have a question for Nicole.
Go ahead, Sammy.
Hi, Nicole. It's Sammy Asher with KPCA. Just one
Hi.
quick question. At your regional offices, are your staff equipped or knowledgeable about the redetermination with Medicaid? Are you having members come in and get help with that?
Oh, yes, they can come in and ask questions about it. We can guide them through any questions that they have. We also make calls every day from the one-stop help centers about redetermination. So we get a list, and then we call those folks our rep specialists is what we call them, community engagement specialists. They make calls, and we're doing about 500 calls a week to members to inform them about redetermination. And then at all of our events, we also discuss redetermination. So we're doing that anywhere and everywhere we can.
Okay, so those folks that are coming into the offices, they don't have, well, obviously, if they've lost their coverage, they're not passport specific, but they don't have to be passport specific members in the past.
No.
You're helping everyone that comes in. Perfect.
Yeah,
Thank
if anyone comes into the office, and sometimes, you know, people come in there and they don't have insurance, and we just direct them to a connector, and then so they can go that way. If they are asking about redetermination, then we can direct them as well.
Right.
You know, of course, the goal is to get members, but what we don't want is anyone, no matter what plan they're with, to lapse on their insurance.
Right. Perfect. Thank you. Good job.
You're welcome. Thank you. Hi,
Additional
Dr.
questions?
Hoagland.
All right, so moving on to Humana.
Hi, this is Kristen Mauder. I'm the Health Services Director for our Medicaid program. So today we'll talk about some of our engagement opportunities that we have. First of all, we have our case management and population health program. So we have integrated physical health and behavioral health case management. We have a chronic condition program. We have a Humana Beginnings, which is a maternity program that we focus on high-risk maternity members. We have an ER diversion program. We also have a housing program, a workforce development program, and community health workers that focus on SDOH. But what we really want to focus on today was more of our community collaborations and partnerships that we have. So part of one of the things that we do is try to connect and address the transportation needs of our members. So through our case management and our population health programs, we work with the Kentucky Department of Transportation to connect with those non-emergent transportation needs. We also have a few pilots that we do. So we have a behavioral health transportation assistant pilot that we are doing with 7 counties. So what that pilot is we provide vouchers for 150 members. And that's for them to go to follow-up appointments, get lab work, and preventative screenings. And with that, one thing that we do is they have to, 7 counties has to fill out the health risk assessment and send that back to us. So that's the mechanism that we use to be able to provide that transportation voucher. Another pilot that we do is around maternity. It's with a program called Doula Dash, and it works similar to like an Uber or a Lyft, where they have drivers who are trained by prenatal health professionals and doulas. It assists members in Louisville or within a 30-mile transportation to their visits and for well child visits, WIC appointments, prenatal education. And they also provide child care while the member is at that appointment. One of the other programs that we have is our workforce development program. And so our program is statewide, and we engage members who are 18 or older. And we provide 3 round trips per month, depending on the transportation available in their geographic area. And then another part of our rewards is members are able to earn rewards through our Go 365 wellness program. And through that, they can purchase gift cards like Uber gift cards. So another program that we have is we're doing a collaboration with Humana, Aetna, and Samaritan to help at least 200 Kentuckians address health-related social needs and achieve their health and housing goals. And a subset of that, of the enrollees, are with insulin requiring dependent diabetes. So what Samaritan does is they'll work with case management teams in Louisville to reach that targeted 100 Humana members or Aetna members, and they'll give them a free 12-month membership to Samaritan. So participating Samaritan members share SDOH goals and then set short-term action steps and meet with their case managers or appropriate staff from like Volunteers of America, Goodwill, St. Vincent de Paul, or other community-based organizations that are already engaged with Samaritan. The membership is a 12-month membership. It'll help them gain financial support, so no less than $40 a month. The relational support with Samaritan to meet their critical needs, such as like clothing, their bills, or medication, and rewards steps towards their goals that they're taking, like talking with the housing specialist, getting their prescriptions filled on time, and attending things like diabetes self-management programs. And then the last program we want to talk about is our partnership with Melanated Health. So Melanated Health is a digital company, and they also provide medical practice that focus on healthcare technologies and services. They are empowering and providing Black, Indigenous, and people of color and underserved communities access to quality, cultural, competent healthcare professionals. So we have provided funding to expand the app to telehealth services. This pilot started in September of 2023. We addressed the gaps for the prenatal care. It aims to reduce preventable poor pregnancy outcomes, addresses late or insufficient access to care, and also provides Spanish and language services to our Latin population. And so that's kind of an overview of some of our community partners that we're working with and programs that we have to help members engage with services in the community. Any questions?
I don't have a question specifically, Kristen, but a comment. I appreciate your conversation around transportation. You know, I think in primary care, it's probably one of the things that comes up most often that we have challenges addressing. I would encourage you to, and all of your MCO colleagues, the transportation situation in rural communities is quite different. Uber is not an option. You know, there's not Uber in McKee, Kentucky or Irving, Kentucky. And so we really struggle. And so what ends up happening is oftentimes it's sort of end of day urgent needs. And so what's really most helpful is if there are ways that providers could have gas cards, because sometimes they might have a friend or family member who's willing to get the member to where they need to go, but they don't have gas money. So, you know, if some thought could be given to some creative ways about how we can solve those issues in rural communities, because what happens, it's a running joke at our office. It's like, if you're the last person here Friday at 5:30, you're going to be figuring this out. It's people who need to go, you know, non-emergently, but urgently, to the ER, to, you know, behavioral health, inpatient facility, situations like that. A lot of times families need to get to specialty appointments, you know, sort of same day kinds of things. So Medicaid transport isn't a great option. And then, you know, there's not another mechanism to get these families. So we've been spending a lot of energy on that internally. And that's a great area where, partnership could really help us better serve patients.
Okay, I'll definitely take that back to our group where we discuss our value added benefits and put that forward as one of the options for us to look at. Thank you.
Thank you. I think Anthem is up next.
Hi, everyone. My name is Victoria Jude. I'm the Director of Marketing for our Anthem team and lead our community engagement outreach strategies to best support both members and community partners in the field. So I do want to start off with highlighting a few of the VABs, just calling them out for 2024 and some of our various programs that we do have to best support our members. And then I'll go into some new member engagement and then kind of end off with a few helpful tools and resources we have for members through the renewal and redetermination process. So starting off with the VABs, I do want to start off with our transportation assistance because we do provide all gas cards, Uber cards, and bus passes as options for our transportation benefit. It's $100 worth of supports for those for members that have completed their health risk assessment for the year. And then we also have year for anyone with a diagnosis of obesity, asthma resources for members under the age of 18 with a diagnosis of asthma that provides various relief solutions from inhaler vaporizing kits to travel nebulizers, hyperallergenic bedding, air filters, pillow covers, mattress covers, things like that to help with the management piece of that. We also this year have our air fryers for individuals with a diagnosis of diabetes, and we have a healthy cooking class for those individuals as well to help provide that wraparound support for those individuals seeking diabetic friendly meals. And they'll actually get from those cooking classes the ingredients to create and replicate those meals at home to take home with them as well. And then we also have various programs such as our LARC and Livongo programs that help with individuals experiencing pre-diabetes or a diagnosis of diabetes to provide that preventative and long-term care support. And then in the field, we have a team of community relation coordinators and a team of member empowerment engagement navigators located across the entire state of Kentucky that are all CHW certified, both working with the members, working with the community partners to provide that one-on-one support for our members that may be having limited access to health resources or may be experiencing social determinants of health barriers. So our member empowerment program, we work very closely with, and they're able to work directly with our members to aid in any type of housing assistance for individuals experiencing homelessness or at risk of homelessness or in transition of housing, and food assistance for members experiencing any food insecurities, along with any type of education and employment supports, and even the record expungement process, working with our local legal aid offices. And then for our community relation coordinators, we actually have education hubs across the state of Kentucky with local community-based organizations. We have areas that at these education hubs, we also have diaper pantries and health and hygiene closets. And then just at the end of last year, we launched 6 food pantries in schools in partnership with Feeding America. And we have both community relation coordinators and member empowerment navigators that have ongoing schedules at those locations to aid members through to provide that wraparound support. And so for individuals moving on to those that are new members, we do have welcome packets that go out to our members that have both resources around provider directories, completing the health risk assessments so we can tier our care plans and meet the needs of our members early on and provide that wraparound support for any case management and getting them connected to programming. Some of our, in that welcome packet, we also have resources around language lines, interpreter services, and we, within that time, they receive that packet within 5 days of enrollment. So following that packet, they also get a welcome call from us to help make sure they're aware of the resources that they've received. If they have any questions or feedback, getting them that direct one-on-one support if needed. And then we also offer member orientations, and they can access this through a variety of avenues. We post them on our website, we post them on our Facebook. We also have a blog where we have the entire year schedule available, and we offer those in both English and Spanish throughout the year, where we'll actually talk through any terms that they're not familiar with, their card on the member ID card that they receive in the mail, and talking to them about what does PCP mean, what does we have the primary care dentist on there as well, talking to them about how to navigate those resources and taking those next steps to get involved in utilizing their value-added benefits, but also getting connected and referred into specific programs that they may be interested in as well. I do want to say, as part of those efforts, we continue to try to gather feedback and resources to better support our members. And so we have taken the approach this year with what many refer to as the QMAC. Our Anthem Health Collaborative we provide that virtually and in the field. Our first one's going to be on March 25th in Paducah, where we're going to have an opportunity for our community partners and our members to come together and discuss feedback around dental access and different services that we provide to better gauge how to support our members in Western Kentucky and getting them connected to our dental home program out there. And then for redeterminations, we host throughout the year on a monthly basis health and resource days at our local education hubs, so we can best support individuals. Our community relation coordinators are able to guide and assist through the renewal application process. And we also have a call center for Anthem as well to directly work with those individuals as they are reaching out to Anthem and providing those supports. So far, through the redetermination process, we've been able to deploy over 55,000 member communication campaigns. So.
Great. Thank you, Victoria. And
Thank you.
last, but usually first, Edna.
This is Tabitha Sage. I'm the Quality Practice Liaison for Aetna. Similar to all the other MCOs, we do have a lot of great programs as well. We have a great community outreach team that works with a lot of local community events such as back to school bashes. We work with food banks and do a lot of great outreach there. We have a great SDOH program. We have community health workers. Our SKY team is for our Kentucky youth. We have a great program there, a great member services team as well, and a lot of care managers that work with our SKY members. As far as our incentives, we do have a great Maternity Matters program. We help outreach those pregnant moms, getting them to their prenatal visits. We offer a a $25 gift card for getting that initial visit, and then have $10 subsequent gift cards for every visit after that. And then we have a gift card for our postpartum visit as well. So we make sure that they're following up after the delivery. We do also offer up to $90 for those new moms to get either a car seat or a portable crib. So we have that available for those new moms as well. We do have programs for some of the chronic diseases, such as slow cooking classes, home delivered meals, as well as the others. But I do also want to point out that this year we've added some great incentives for our members that are kind of geared around some of those priority measures that I know all the MCOs are focusing on this year. A couple of the big barriers I know that everyone has probably faced is around flu vaccines and HPV vaccines. So we did add incentives this year for the members to receive a gift card for completing 2 flu vaccines by their 2nd birthday and an HPV series by their 13th birthday. So doing a lot of outreach there to help with those barriers that we see as well. And I just want to say to providers, we do send our value-added benefits out with our providers. I myself work very closely with our value-based program providers on gaps in care, making sure that they're hitting their targets. And we do provide these value-added benefits and mention them with every visit. And we do have a lot of providers letting the members know about these incentives, which is great. And I just want to mention that if you do have members that reach out to you saying, I was supposed to get a gift card and I haven't done so, please refer them to member services so that you all are not having to deal with getting that for them. That puts that back on us, and we will get our member services involved to help the members make sure that they're getting those gift cards for their incentives. Are there any questions? Okay, thank you.
Thank you. I think one of the challenges is at the care delivery level, there've been 6 presentations with slightly different benefits. So it's really difficult for the care teams to know when they're eyeball to eyeball with the patient, what the benefits are within that particular MCO. So I know we're still working on trying to figure out how to increase that engagement and help make people aware, but it's certainly a challenge.
Stephanie,
Yes.
I do want to let you know for Anthem that we have a provider pamphlet that has member incentives, both the value added incentives and the healthy reward incentives available, along with like a provider training to help support that as well. Because I know while time is of the essence and very limited to be able to refer back to those trainings, those virtual trainings, we do want to make that a little more accessible and available as the provider is working directly with the patient for any Anthem members.
Okay, thank you.
I also think, and maybe someone on the team Medicaid can confirm, but I do believe we have, hopefully maybe it's helpful, a snapshot of every MCO's value added benefit. So at least at a high level, you can quickly just pull that out and see what the value added benefits are. It's all encompassed on one page. Is that anybody from Medicaid?
Yes. Yes.
We still do that.
Yes. We have the value added benefits side, what we call side by side. It is on our DMS website, but we can also have Aaron or Kelly send that to the TAC members as well.
Yep.
Aaron, can you hear me?
Yeah, it's very well done.
This is Aaron on Kelly's computer. Sorry about that. I'm having issues. The value added benefits for 2024 was emailed out to all of the MAC and TAC members. I want to say several weeks ago, but I'm happy to pull that and resend it to you guys after the meeting.
No, didn't you say, is that what you sent like maybe last week, Aaron?
I have sent it twice. I received one and then also received an updated one. And sometimes all those email blasts tend to run together. I know it was fairly recently that the revised one went out, but I'll pull that and send it in your all's updated meeting. And again, I apologize for all the Zoom problems.
That's great. I don't know if anybody can quickly maybe go out to our website and pull the link to add to the chat for everyone that's on the call today, I think would be helpful.
I can do
Try
that.
to do that, Aaron.
Yeah, we talked about this years ago, and you guys did pull together the sheet. So we really appreciate it. It is helpful.
One of the things that I'm thinking about just in looking at it is, trying to almost put on the other axis, the common barriers that we see in the clinic. So like, creating a sheet that says transportation, and here, if you've got a member who's having a transportation problem, here's what their particular MCO is able to offer to support that. One of the other things that we see pretty frequently, Barry, I don't know, Dennis, if you guys see this as well, but when you're referring patients to specialists, particularly specialists not affiliated with a large system, they oftentimes aren't offering translation services, and they're punting it back to the primary care provider to send a translator with our patient that we're referring. So having that at the quick and ready probably is helpful as well.
We don't have much of that problem in Eastern Kentucky, but I know farther west, it does become a problem.
Maybe you're just good people out there, Barry, and when you get west.
No, I think we have less of a population.
All right. So other business from committee members to bring forward today?
Stephanie, I know I'm not a committee member, but just if I could chime in real quick, I don't want to make the day longer for everyone, but with all the communication issues that are going around, I just for the with AT&T, other cellular, there have been some emails going back and forth, but for those that aren't familiar with FirstNet as providers, I mean, there's some logistic things, and Stephanie and I have been sharing some emails around that about whether it's personal devices or if it's company owned, et cetera. But I think the rules around FirstNet have broadened at the national level, allowing more access to people working in healthcare fields. So just something to maybe think about, which that system does allow for outages to shift to other carriers a lot easier than it does just switching cell phone towers. And it also prioritizes email and other communications coming off of those devices so that you get less slowdown even in kind of normal time. I'm not necessarily making a sales pitch for AT&T and FirstNet on this necessarily, except in that it does seem to make a difference in being able to have consistent access for those that are involved in the healthcare fields. And again, initially it was just first responders and licensed individuals. It is now much more expanded. So, for those that are part of the association, I think we've had some communications going out around that, but just kind of making a broader pitch as well. If it's a service that can be available to those that are touching, the service of peoples and communities, it's something we should really explore.
Yes, thank you. We already have been impacted by that multiple times today. It's amazing how much you rely on things and don't recognize that. Other business to discuss today? Right. Are there specific recommendations that need to be made to the MAC?
I don't think out of today's meeting we've had any, have we?
I didn't think so either.
Yeah.
Right.
Just keep up the good work.
All right, our next meeting is June 27th. So barring any other business, is there a motion to adjourn the meeting?
I make a motion to adjourn.
Thank you, Barry.
I'll second.
Thank you, Dennis. All right, meeting adjourned. Thanks for your time today, everyone.
Hey, thank you all.
Thanks.